We're going to go ahead and get started. Today we're going to be presenting an industry perspective on telemedicine. This is the 14th installment of our educational webinar series, and we hope that you find it interesting and insightful. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for Attentive. I'd like to take a moment and explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, I'm pleased to announce our upcoming webinars. First, we can finally announce that the CMS announced the Meaningful Use Final Rule. We are assembling a webinar on it as we speak, and we'll have that ready for this coming Tuesday. I will be sending out an invitation to that and posting it on social media tomorrow, so block your calendars now. We will break down the final decision and how it affects you in this webinar. Also, I'm excited to announce we're mixing up our normal routine for these next webinars by doing a 4-part series covering government regulations and ramifications. The first one is on October 11th and covers meaningful use audits. We will help you prepare for an audit, decipher and highlight key information to have in your audit binder. Then on October 18th, we will discuss EHR cloning. What is it, who is committing it, how it affects your practice, and other important information. Then in December, we will cover the dangers of information blocking and its effect of interoperability, and where we will help you discover if you are a victim of it or perhaps even participating in it, common practices, and how to combat it. Our final one in the series will be on high-tech security and Hipaa. That will also likely be in December. Exact dates for the last two remain to be set, but follow us on social media, check out our website, or keep your eyes out for emails from us for the set dates. Okay, so moving on to our current webinar on telemedicine, some housekeeping notes. At the end of the presentation, we will open the floor up to questions from you. We will answer all these questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we will also be emailing out links to the recordings and a PDF of the presentation later this week. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please let us know using the chat box so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenter for today, Lindsay Lambing. Lindsay joined us originally from the Ohio State University intern program, where she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as Healthcare Informatics Coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Lindsay is also our newest healthcare blog author. Her first post on information blocking will be going up later today, so check it out and subscribe to be notified of future posts. So Lindsay, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Perfect. Thank you, Chelsea. Hi, everybody, and thank you for taking time out of your busy week to sit in on this webinar regarding telemedicine. So to begin, I want you to ask yourself, telemedicine, is it the future of healthcare delivery? Right now, we're seeing healthcare rapidly evolve from a volume-based to a value-based delivery. And with this shift, I would say yes, absolutely, we're going to see a lot of changes, one of these being the expansion of telemedicine. So this growing trend we see in the healthcare industry today is also leading to a lot of questions. Here are some of the most common ones we hear of. Is there a difference between telemedicine and telehealth? How will wearable technology and mobile health apps affect telemedicine? Can physicians practice telemedicine across state lines? Does telemedicine only consist of live video conversations? And is reimbursement different for telemedicine services compared to in-person services? My goal at the end of this webinar is for everyone on this call to not only be able to answer to these questions, but to understand the who, what, when, and how behind it as well. So to get started on the agenda today, we're going to talk about telemedicine versus telehealth, the elements of telemedicine, the modalities and delivery mechanisms of telemedicine, the benefits and the obstacles, with a highlight on reimbursement and licensure, recent legislation and its impact on telemedicine, and the future of telemedicine, really focusing on the use of wearable technology and mobile applications. So what is telemedicine? Telemedicine is defined as a form of telehealth, which is the delivery of clinical healthcare services by means of real-time two-way audio, visual, or electronic communications. This includes the application of secure video conferencing or store and forward technology to provide healthcare delivery. Healthcare delivery can include anything from assessments, diagnosis, consultations, treatment, education, or even care management. A stipulation of this definition is that care should be given by a physician providing care within his or her scope of practice in the same manner as they would if they were seeing the patient in person. The end goal of telemedicine is to really have an experience that is as close to what the normal in-person visit would be like. So a provider must have the appropriate licensing requirements, which we'll talk about later because this is where things tend to get a little messy, as well as be practicing within their usual scope of work. Telemedicine versus telehealth. Telehealth is different from telemedicine because it refers to a broader scope of remote healthcare services than telemedicine. While telemedicine refers specifically to remote clinical services, telehealth can refer to remote non-clinical services, such as provider training, administrative meetings, and continuing medical education, in addition to clinical services. So, yes, there is a slight difference that can be identified since telehealth technically includes telemedicine. But for the purposes of this presentation, I will be using the words interchangeably since almost everyone else in the industry does as well. It's very rare that you see someone distinguishing between the two, but I did want to point this out before we get any further, because essentially no two states are alike in how telehealth is defined or regulated. Now we'll go ahead and look at the fundamental elements of telemedicine. So its purpose is to provide clinical support. It is intended to overcome geographical barriers, connecting users who are not in the same physical location. It involves the use of various types of communication technology, and its goal is to improve health outcomes. I think those are all pretty self-explanatory and what you would really expect. Telemedicine modalities. So these are the different types of communication methods used for telemedicine. Number one is live video. So this is live, two-way interaction between a person and a provider using audio-visual technology. This type of service is also referred to as real-time and may serve as a substitute for an in-person encounter when it's not available. Live video can be used for consults and diagnostic treatment services. So when I say live video, this is when we're talking about different applications like Skype or FaceTime that we're used to using. Two is store and forward. So this is the transmission of recorded health history to a provider who uses the information outside of a real-time or live interaction. As compared to a real-time visit, this service provides access to data after it has been collected. For example, think of pre-recorded videos and digital images, so x-rays or photos that were taken. This is most commonly used by specialists who are receiving information about an incoming patient. Number three is remote patient monitoring. So this is personal health data collection from an individual in one location, which is then transmitted to a provider in a different location for use in their care. This type of service allows a provider to continue to track healthcare data for a patient once released home or to a care facility, and it often reduces readmission rates. And lastly, mobile health. So this is healthcare supported by mobile communication devices, such as cell phones, tablets, and computers. Applications can range from tracking your daily heart rate, your exercise, or even your cholesterol intake. These last two, remote patient monitoring and mobile health, are where we're really seeing the industry just explode with new technology, and we're seeing a greater acceptance of these methods. I think it's also important to note that telemedicine is not a telephone conversation. It's not a fax, and it's not a text or an email. The modalities we just went over go much farther than a phone call or an email ever could. So telemedicine delivery mechanisms. Not to be confused with what we just went over, this is how information from an originating site is actually transmitted to a distant site. To clarify, the distant site is where the person delivering the service is located, so the provider, and the originating site is where the patient receiving the service is located. So the first being networked programs. They link specialty hospitals, clinics with outlying clinics, and community health centers in rural or suburban areas. So the links they use here may be dedicated high-speed lines or the internet for telecommunication between these sites. Number two is point-to-point connections, and they're using private high-speed networks used by hospitals and clinics that deliver services directly or outsource specialty services to independent medical service providers. So outsourced services, think radiology, stroke assessment, mental health, and intensive care services. Monitoring center uses links cardiac, pulmonary or fetal monitoring, home care, and other related services. So often normal landlines or wireless connections are used to communicate directly between the patient and the center, although some systems do use the internet. And then finally, web-based e-health patient service sites, and they provide direct consumer outreach and services over the internet. So with this, you can think of a website patients can access and get answers to their health-related questions from a healthcare professional on that. So we've kind of gone over all the basics of what telemedicine is, the different types of communication methods used, and the way information is transferred. So let's start looking at its effect on the industry. The benefits. What can telemedicine do for the healthcare industry today? Number one is improved access. Telemedicine improves access to patients, but it also allows physicians and health facilities to expand their reach beyond their own offices. Given the provider shortages throughout the world, telemedicine has a unique capacity to increase service to millions of new patients. It allows care to go past what we call the traditional brick-and-mortar approach. Cost efficiencies. Reducing or containing the cost of healthcare is one of the most important reasons for funding and adopting telemedicine technologies. Telemedicine has been shown to reduce the cost of healthcare and increase efficiency through better management of chronic diseases, shared health professional staffing, reduced travel times, and fewer or shorter hospital stays. Improved quality. Studies have consistently shown that the quality of healthcare services delivered via telemedicine are as good as those given in traditional in-person consultations. In some specialties, particularly in mental health and ICU care, telemedicine delivers a superior product with greater outcomes and patient satisfaction scores. And lastly, patient demand. Using telemedicine technologies reduces travel time and related stresses for the patient. Such services offer patients the access to providers that might not be available otherwise, as well as medical services without the need to travel long distances. And the obstacles. So as you will see, there are multiple barriers to the widespread uptake of telemedicine, but the most prohibitive are regulatory policies at the state level. State legislation with the following 4 elements is needed. First, the legislation needs to provide a payment parity. This means requiring insurers to reimburse licensed healthcare providers for services delivered remotely at the same rate they would pay if the visit were in person. Currently, only 21 states and DC have parity legislation, and of those, only 15 do not have provider or technology restrictions attached to them. Second, the legislation should establish that the same standard of practice applies whether the services are delivered in person or remotely. This means codifying that the questions and images a physician uses to adequately diagnose or treat a patient are the same whether they are gathered in person or over the phone. Third, there needs to be legislation that would prevent the creation of more restrictive licensing requirements by each state for delivering services via telemedicine. Specifically, the legislation should prevent the use of additional rules requiring in-person visits before or after telemedicine encounters. These types of restrictions make it almost impossible to deliver quality, cost-effective care remotely. Currently, 27 states and DC have legislation that is telemedicine friendly. However, a number of states require an initial in-person visit before a telemedicine visit, and even more states require an in-person follow-up visit. These laws effectively eliminate the possibility of most telemedicine models from operating in state and essentially take away the entire purpose of telemedicine to eliminate travel and the need for an in-person visit. Fourth, the state licensure requirements should allow exemptions for telemedicine. All states currently have some restrictions on physicians practicing out of state, despite that the Federation of State Medical Boards offers a uniform licensing procedure and guidelines. Each state has a different set of policies and practices. Only DC, Maryland, New York, and Virginia have reciprocity agreements with bordering states. Currently, some states offer a conditional license for telemedicine for out-of-state physicians. Telemedicine does have the possibility to travel across state lines, which raises questions about which state laws and professional licensures apply. So this is what I was referring to when I said things tend to get messy trying to navigate between each state's own regulations. They define telemedicine differently and they regulate it differently. So again, going off that last bullet we talked about, the current state of physician telemedicine licensing is not conducive for interstate treatment and will need to change to see further improvements. Right now, 49 state boards plus DC require that physicians engaging in telemedicine are licensed in the state in which the patient is located. 13 state medical boards issue a special purpose license, telemedicine license or certificate, or license to practice medicine across state lines to allow for the practice of telemedicine. You can see these states are listed below. And then one state board, Minnesota, requires physicians to register if they wish to practice across state lines. The next biggest issue is the current state of reimbursement. We are quite literally all over the map. There may be at least a half dozen bills pending in different state legislatures currently under discussion. We will see more states passing these laws. We may also see those states with existing telehealth coverage laws going back to the table to consider statutory language that more accurately reflects the current state of telehealth in this country. Many states are enacting laws requiring commercial health plans to cover medical services provided via telehealth to the same extent they cover medical services provided in person. These laws are intended to promote innovation and care delivery in the private sector by catalyzing healthcare providers and plans to invest in and use the powerful telehealth technologies available in the marketplace today. Currently, 18 states and DC require both private insurance companies and Medicaid to cover telemedicine services to the same extent as face-to-face consultations. 20 states require only Medicaid to cover telemedicine services. 9 states do not require any reimbursement parity for telehealth. 22 states and DC require state-regulated health plans reimbursed for telemedicine services with rates on par with face-to-face consultations. And 24 states require private insurers to cover telehealth services in the same way as corresponding in-person services. These laws are expected to drive the commercial insurance market, allowing telehealth to be enjoyed by more patients across the states. Successes in these states with parity legislation will signal the promise of telehealth coverage and payment parity to the remaining states as they consider their own legislation. Branching off reimbursement to telehealth coverage. Telehealth coverage laws require health plans to cover services provided via telehealth to the same extent the plan already covers the services if provided through an in-person visit. So the laws do not mandate the health plan provide entirely new service lines or specialties. The scope of services in the plan's member benefit package remains unchanged. So if the service was covered in your plan normally, if you receive that same service via telehealth, it still needs to be covered. Telehealth coverage laws also frequently include language to protect patients from cost shifting. This is reasonable and logical because telehealth is not a separate specialty, but simply a technological conduit through which the physician provides care. They disallow health plans from imposing different deductibles, co-payments, or maximum benefit caps for services provided via telehealth. Any deductibles, co-payments, and benefit caps apply equally and identically whether the patient receives the care in person or via telehealth. Most states have elected to expand on telehealth coverage with 2 additional topics, remote patient monitoring and payment parity. So diving headfirst into these 2 topics, the first concept, remote patient monitoring, includes a variety of patient oversight and communication devices to allow providers a greater ability to monitor patient care needs and immediately respond. Clinical benefits are significant and well established, particularly for chronic disease management. Some states have enacted laws requiring health plans to offer remote patient monitoring as an additional service in the member's benefit package. States have taken this step because remote patient monitoring, by definition, is a virtual, distance-based service and does not have an in-person equivalent that would likely already be found in the benefit package. The second concept, telehealth payment parity, requires health plans to pay providers for telehealth services at the same or equivalent rate the health plan pays the provider when the service is provided in person. Keep in mind, payment parity does not change the plan's existing utilization review processes. So the doctor's services, whether in person or via telehealth, must still be of high quality, appropriately documented, and medically necessary in order to be paid. Payment parity is in part a response to avoid the problem of health plans paying for telehealth services at only a percentage of the in-person rate or imposing restrictive conditions on telehealth. In greater part, payment parity is intended to level the playing field for healthcare providers to enter into meaningful negotiations with health plans as to how telehealth services are covered and paid. We will now go ahead and look into both Medicaid and Medicare reimbursement. So nearly 20 years after such video conferencing technology has been available for health services, less than 1% of Medicare beneficiaries use it. 1%. That truly is hard to believe when we think about how much technology has become of our daily lives. The Medicare statutory coverage conditions and definitions are restrictive, requiring qualifying originating sites and rural patient locations and other requirements. Although this year Medicare did expand telemedicine coverage for mental health services and annual wellness visits. So we are seeing some progress being made here with that expansion and a greater acceptance. Although at this time, better opportunities for telehealth providers can be seen among Medicaid managed care organizations and Medicare Advantage plans. Medicaid reimbursement. Reimbursement for Medicaid coverage services, including those with telemedicine applications, must satisfy federal requirements of efficiency, economy, and quality of care. States are encouraged to use the flexibility inherent in federal law to create innovative payment methodologies for services that incorporate telemedicine technology. So what does this mean? For example, states may reimburse the physician or other licensed practitioner at the distance site, so where the provider is, and reimburse a facility fee to the originating site or where the patient is. States can also reimburse any additional costs such as technical support, transmission charges, and equipment. These add-on costs can be incorporated into the fee-for-service rates or separately reimbursed as an administrative cost by the state. If they are separately billed and reimbursed, the cost must be linked to a covered Medicaid service. Medicaid guidelines require all providers to practice within the scope of their State Practice Act. Some states have enacted legislation that requires providers using telemedicine technology across state lines to have a valid state license in the state where the patient is located. Any such requirements or restrictions placed by the state are binding under current Medicaid rules. So again, we see that reinforcement from CMS that we saw in the definition of telemedicine. Those conditions that you must have the appropriate licensing and be practicing only within your usual scope of work. Medicare coverage. There have been several bills introduced in Congress that would further increase the use of telemedicine, such as allowing Medicare payments for remote patient monitoring in the home, providing Medicare coverage for round-the-clock emergency support via telehealth tools, and expanding the use of telemedicine in the TRICARE Veterans Program. Additionally, effective January 1st, 2015, telehealth-based chronic care management was introduced as a new service covered by Medicare. Medicare Telehealth Parity Act. So on July 7th, 2015, the Medicare Telehealth Parity Act of 2015 was introduced. The legislation intends to modernize the way Medicare pays for telehealth services. It contains 3 implementation phases over a 4-year horizon, and the Act proposes changes to Medicare telehealth payment methodologies and expands coverage not only to residents of rural areas, but urban areas as well. So this Act is intended to reduce barriers to interstate care, bringing more options to underserved areas and allowing providers to expand their reach. But keep in mind, the Telemed Act proposes a change to Medicare coverage and reimbursement rules. It is not a federally imposed change that eliminates state laws requiring a physician to be licensed in these various states. Even if Medicare does not require state licensure for payment purposes, the Telemed Act does not eliminate the licensing requirements in place for each individual state. Basically, this is just trying to say the Medicare Telehealth Parity Act does not preempt any state laws like a normal federal ruling would. The Act also includes provisions for Medicare coverage of remote patient monitoring services for covered chronic care conditions and home dialysis services for those with end-stage renal disease. The 2015 Act represents federal lawmakers' continued and increasing support for expanding Medicare telehealth reimbursement. So this is a big step for Medicare towards the increased use of telemedicine services, and it only happened a few months ago. The next act we're going to talk about is the Doc 6 bill. This is also called MACRA, or the Medicare Access and CHIP Reauthorization Act. So this act includes specific provisions benefiting telehealth and remote patient monitoring, particularly for the Medicare program. It states, telehealth and remote patient monitoring are expressly recognized as and included in the definition of clinical practice improvement activities, along with care coordination, population health management, and monitoring of health conditions. New alternative payment models, or APMs, may include payment for telehealth services, even if the service is not otherwise covered by the traditional Medicare program. So again, this as well is a big deal for telehealth services. As we see a shift from volume to value-based care, there's been a strong focus on APMs, or alternative payment models, and increasing their usage. So for telehealth to be considered one of these shows the backing and acceptance it's slowly gaining. There are other reimbursement options available. For example, if healthcare systems had their own doctors do virtual visits, they'd have to figure out how to pay them for their time. Currently, most groups pay physicians on productivity, so they'd have to change their compensation model slightly. So the Centers for Medicare and Medicaid Services Next Generation ACO model, which was announced in March of this year, expands coverage and reimbursement to providers for telehealth services. This offers ACOs another financial incentive for offering behavioral health services online. So this program allows ACOs to treat the whole patient, not just the physical symptoms. By offering patients the behavioral health care they need, the entire ACO ends up reducing costs due to the many ways mental health impacts physical health. To experience these benefits, however, online behavioral telehealth program selection is crucial, and they vary in quality and usability. The gold standard online behavioral telehealth program at present does not have a commonly accepted definition. However, it should include the following criteria. And that's the use of evidence-based content. It should focus on achieving clinical outcomes, be developed on robust, engaging, secure, and responsive technologies, be informed and developed by behavioral health subject matter experts, be patient-centered and highly personalized, and have research and evaluation supporting its effectiveness. It has found that online behavioral telehealth programs address mental health care gaps while offering users options beyond face-to-face therapy, which encourages treatment adherence and improves clinical outcomes, ultimately lowering the cost of care for these ACOs that are utilizing this. Now, our last topic before we start to look at wearable technology and the mobile applications, which is a hot subject right now, is remote prescribing of controlled substances. So remote prescribing remains an area of concern for state medical boards, and a number of states require an in-person examination of the patient prior to issuing a prescription. But with that requirement of an in-person visit, my question is, what's the point of having telemedicine in the first place? You still have to go in. You still have the wait time and the travel time we're trying to avoid. Federally, remote prescribing of controlled substances is governed by the Ryan-Haidt Act. The Act and its regulations require a physician to conduct at least one in-person medical evaluation of the patient before prescribing any controlled substances remotely. Once the prescribing practitioner has conducted an in-person exam, the regulations do not set an expiration period or a minimum requirement for subsequent annual reexaminations. Several states expressly permit remote prescribing of controlled substances, but the federal act preempts state law, meaning the Ryan-Haidt Act still needs to be followed no matter what, and at least one in-person evaluation needs to occur always. All right, now let's look at what I would consider the most popular sector of telemedicine today. Mobile apps and wearable technology. So telehealth apps and Hipaa. With the 2014 and 2015 changes in FDA's guidance on mHealth apps and medical devices, many telehealth app developers appear to be focusing their regulatory attention primarily on whether or not their app is considered a medical device. Less attention appears to be focused on the privacy and security of their products. So why do they care if their app is considered a medical device? Well, the FDA is taking a new approach that focuses on the small subset of mobile apps that meet the definition of a medical device. So app developers are all worked up over whether their product will be regulated by the FDA or not. So if it's considered a medical device, it will be, but if it's not, it is not subject to the FDA's guidelines. App developers, covered entity, business associate, or neither. In reality, an app developer frequently is not a covered entity subject to Hipaa rules. And in many apps, the developer isn't even a business associate either. The specifics depend on the nature and the function of the app itself. But simply because an app collects identifiable health-related data does not mean that the app is subject to Hipaa. Similarly, a wearable health app used by a consumer is not necessarily subject to HIPAA as well. So an app could be regulated by the FDA or be subject to HIPAA, or it may not be subject to any of them. It will just depend, and as consumers, it's important that we're aware of this. Bottom line, addressing privacy and security issues should definitely be on the to-do list of any telehealth app developer's business plan, or at least as consumers, we really hope it is. Devices worn on or close to the body are expected to produce the most groundbreaking innovations. There's increasing clinical evidence of the value of continuous physiological data in managing chronic conditions and monitoring patients post-hospitalization. As a result, a growing number of medical devices are becoming wearable. These are things including glucose monitors, ECG monitors, pulse oximeters, and blood pressure monitors. When clinicians can collect information on patients anywhere and any time, the increased knowledge can lead to earlier detection of problems, preventing readmission, and resulting in better clinical outcomes. Another consideration is the amount of data that these devices generate. For payers and providers, while these devices give better insights on a patient's medical condition, more data brings greater risk of data breaches and more responsibility to implement tighter security and access controls. Physicians will need this data to be integrated into their IT systems, and they will have to change their workflow to accept and use this external data. So right now, we're seeing these devices being worn and being used, but that next step will be to integrate that data into our IT systems. So, wearable technology. Gadgets that companies such as Nike, Fitbit, Jawbone, and Apple have recently produced and brought to market that can record our heart rate, calories expended, and steps taken are shifting purpose to help those who truly need it most. People with chronic medical illnesses such as emphysema, diabetes, or even congestive heart failure. This will lead to remote patient monitoring that couples easy-to-use plug-in devices for patients at home with human and automated intervention on the provider side. The real benefit from remote patient monitoring is that you get a window into how patients are doing in the 95% of the time that they're not in front of a doctor or in a hospital. That's where the value really accrues. To take really good care of patients, we have to understand how they're doing in their natural environment. It just makes sense, honestly. So what can wearable technology accomplish? They can put diagnostic testing of basic conditions into the hands of patients. Close to 42% of physicians are comfortable relying on at-home test results to prescribe medication. It can increase patient-clinician interaction. Half of physicians said that e-visits could replace more than 10% of in-office patient visits, and nearly as many consumers indicated they would communicate with caregivers online. It can promote self-management of chronic diseases using health apps. 28% of consumers said they have a healthcare, wellness, or medical app on their mobile devices, which is up from 16% of last year. Nearly 66% of physicians would prescribe an app to help patients manage chronic diseases such as diabetes. And finally, it can help caregivers work more as a team. 79% of physicians and close to 50% of consumers believe using mobile devices can help physicians better coordinate care amongst each other. It's clear from the Health Research Institute's findings that major stakeholders in the healthcare industry, including hospitals, insurers, and the pharmaceutical industry, all believe that major changes will occur in how healthcare is delivered. However, several barriers exist, many of which we have already gone over, but these also include issues of security, privacy, consumer consent, data sharing, fragmented workflows, and digital buy-in, just to name a few more. So mobile apps. Mobile apps are software programs that run on smartphones and other mobile communication devices. They can also be accessories that attach to a smartphone or other mobile communication devices, or a combination of these accessories and software. The widespread adoption and use of mobile technologies is opening new and innovative ways to improve health and the healthcare delivery. Mobile applications can help people manage their own health and wellness, promote healthy living, and gain access to useful information when and where they need it. With some 165,000 health-related apps available, two key data points illustrate how almost all of those apps fall short. Just 10% can connect to a device or a sensor, and a mere 2% of those can sync into a provider's system. This lack of functionality and connectivity could greatly improve, and if it did, it would both boost the accuracy and the convenience of data collection. And that's really where I see our industry is headed. So one example of how mobile apps and wearable devices will start being tied to patient care is a platform called Cafe Well, and it's currently being used in Colorado and Massachusetts. So their platform is to include the healthcare consumer by allowing people to aggregate personal data from wearable devices, health and fitness apps, smoking cessation, and diabetes management programs, and other online tools into a single place. They have negotiated contracts with Weight Watchers, Fitbit, and D-Life, to name a few. These are all brands we're familiar with. And health plans or providers pay to license the content and provide it to their members through an opt-in platform called Cafe Well. So the idea here is that consumers log on with an anonymous username, but are incentivized through rewards or discounts on their insurance premiums to share their information with their health plans or providers. Really, right now, if we look at Fitbit, Jawbone, Apple Watch, they don't tie to anything. And the people using these devices are, for the most part, already healthy. So it's not making the big impact we expected to see. But once these are able to tie into EHR systems and are made available to everyone, we will see this market explode, especially as we shift to a value-based delivery system and we start looking at this idea of preventative care more and more. So what do we see happening now, and what do we see happening in the next few years? Well, CVS Health announced on August 26th of this year that it's teaming up with telehealth service providers American Well, Doctor on Demand, and Teladoc to further services to CVS customers. A CVS pilot test of telehealth through its Minute Clinic chain of in-store clinics ended successfully this July. And on the same note, Walgreens earlier this year said it planned to expand a telemedicine app it started testing in 2014 that lets people see doctors for minor ailments. Walgreens plans to make it available in 25 states and estimates that it would allow it to reach about half of the U.S. population. So no, there are no finalized timelines on this, but it seems to be a race in this competitive market, and I won't be surprised if we see more begin to follow suit. And what else is next? I thought this would be kind of a fun topic to talk about, since it has been in the healthcare news lately, that as telehealth continues to drive change, it has been suggested that what works on land can also work in air. Yes, I am talking about bringing telemedicine to airlines. The airlines have upgraded their communications technology and mobile device policies so that nearly every plane is equipped with Wi-Fi and other technologies, allowing both crew and passengers to communicate in real time with persons on the ground. So currently there are 3 proposed models on how telemedicine can be offered on airplanes. We're going to walk through these. So model 1, they can contracting with airlines to provide services to just the crew. So airlines employ a vast number of in-flight personnel who regularly work long shifts consisting of time spent in the air or layovers in unfamiliar cities. They are exposed to hundreds of potentially sick passengers each flight and are constantly located a great distance from their primary care provider. So telehealth is an obvious convenience for this population. Model 2 would be offering in-flight telehealth services directly to the passengers. Now that nearly every flight is equipped with Wi-Fi, airlines can start offering in-flight services to passengers. This model takes the same business approach as existing on-ground direct-to-patient offerings, but brings it in flight. This is particularly attractive for those people we call road warriors, who often fly for business and have little downtime to fall sick, A great example would be a healthcare consultant. And then model number 3, contracting with airlines to provide emergency services to crew and passengers. So under this model, the telehealth physician would be available to provide expert consult and oversight of a trained airline crew to better triage and manage the patient until the plane lands in case of an emergency. So you might be asking yourself, what about licensure? How is this going to work? It's already a mess between states. How is it going to work in the air? Well, I agree. In-flight telehealth presents a unique question of what state should the doctor hold a license. The general rule in the U.S. is that the physician must be licensed to practice medicine in the state where the patient is located at the time of the consult. One possible reasonable approach is that the doctor should be licensed in one of the following: the state from which the plane takes off, the state in which the plane lands, or the patient's home state. This particularly if the telehealth service is a follow-up to a pre-existing doctor-patient relationship. You may also find yourself asking, what about privacy and security? A patient sitting in the middle seat of a commercial jet may feel less comfortable than if he or she were communicating with a doctor from the privacy of his or her home. Nonetheless, the patient has the right to contact the doctor in flight and consent to the telehealth consult. Of course, the electronic communication transmission and patient record data storage must be private and secure. As the provider should be doing that already, an in-flight telehealth consultation presents no more of a legal concern than a telehealth consultation conducted on the ground. So there you have it. This could be the next big leap for telehealth services. So, what do physicians think about all this? After all, they are a primary stakeholder in this shift to telemedicine. These results and infographics you're looking at right now on the screen came from the Telehealth Index 2015 Physician Survey. You can see the majority of the physicians surveyed were internal and family providers. And if we go ahead and jump down to the next figure and look at the bar chart, we can see phone and email are the primary form of communication. But what stands out to me is the fact that no communication with patients actually occurs more than video communication. You can see video communication is at 5%, and just no communication at all outside of an in-person visit is actually at 6%. Yet, from the pie chart to the right, we see the most accurate diagnosis comes from video communication. This, to me, just doesn't add up and clearly proves physicians should start utilizing video communication to diagnose patients. If we look at the uses for telemedicine, we see a pretty even disbursement of healthcare specialties providers believe this tool could be helpful in. Finally, to the right are the top reasons why physicians want video visits. The top 3 being flexible work-life schedule, the possibility to earn more income, and improving patient outcomes. The top 2 may seem a bit more provider-focused, but telemedicine does overall offer benefits to every stakeholder, and that's providers included. So telemedicine adoption questions. Telemedicine adoption is fundamental to advance an organization's population health and/or accountable care initiatives. Telehealth is no longer a cutting-edge innovation. It is proven technology and a valuable piece of an integrated health system. So we have these adoption questions to help you gauge where your practice is right now. So number 1, do we have an executive leader who will sponsor a telemedicine initiative? If the answer is yes, your organization can focus on integrating telehealth with the overall vision and strategy. If the answer is no, this is non-negotiable to realize telehealth success. Seek to identify an executive, a physician, or a partner who can facilitate a telehealth workshop to educate your organization's leaders and assist in finding the right sponsor. Number 2, how will telemedicine fit within our portfolio of services? So take a step back and consider telemedicine in the context of your organization's strengths, weaknesses, opportunities, and even ways to mitigate threats. Also consider telehealth in the context and frame of your organization's overall vision and strategy. Telemedicine may already be a consideration or have allocated resources, and the detailed plans and experience is all that's needed to implement. Number 3, can we have success with telemedicine? Telemedicine success is strongly dependent on adoption, vision, strategy, and subject matter experience. Your organization may have all four and simply need additional reserve troops to realize its goals. However, it is more common for organizations to lack depth in any one of these four areas, and once the weak areas or needs are identified, the path to success can begin. Number 4, are we stuck in the past with our telemedicine program? Having a limited number of resources or no clear strategy to include executive sponsorship are signs telemedicine adoption is suboptimal. Other signs and symptoms an organization is stuck in the past and resistant to telehealth adoption include, but definitely aren't limited to, only a single or few services being offered, low volumes of utilization, or a lack of clear, reportable clinical and financial metrics or goals. Asking these questions within your organization can assist and speed up your telemedicine adoption efforts now. So after asking yourself those adoption questions, it's important to recognize that there are several important factors that go into developing a strong telemedicine program. Here are 3 things organizations can do now to help encourage physician support. Number 1 being in-depth education and training on new telemedicine technology. Given the saying that it takes 21 days to form a habit, it is unlikely that physicians will change the way they practice medicine or share information after a mere 1-hour lunch training session. Providing adequate educational resources will help increase ease of use into day-to-day activities and ensures that technology investments are well spent. Number 2, put quantifiable, trackable metrics in place to measure telemedicine progress. In the short term, your telemedicine program may save your organization money rather than being a revenue generator. This is particularly true in states without telemedicine commercial reimbursement statutes. But there are other ways to measure the impact of your program beyond dollars and cents. Are you reaching more patients? Are the patient outcomes and quality of care improving? Are readmissions reduced? What about patient satisfaction? Tracking this information, analyzing the trends, and mining the data will prove a key driver in demonstrating the effectiveness of your program to physicians. And lastly, establish clear quality standards for telemedicine services. The American Telemedicine Association calls standards and guidelines the critical foundation for the deployment of telemedicine services. They establish the structure for uniform, quality patient care while potentially accelerating the adoption of services by providers, administrators, and payers. Quality standards help ensure that your telemedicine practice is in line with industry, government agencies, medical societies, and other stakeholder standards. Having strong standards in place helps set the stage for physicians to understand what these services mean for their practice and that what is being implemented meets regulatory requirements. So what will your next doctor's visit look like? The global market for telemedicine is expected to be worth more than $34 billion by the end of 2020. North America is the largest market globally, accounting for more than 40% of the total market size. Driving growth in this market, researchers say, is an increasing aged population, increasing incidences of chronic disease, and a rapid rise in the software market. Also, many healthcare systems are trying to reduce both the number of hospital visits and the length of stay in hospital, which has led to a growing trend for patients to be monitored in their home environment, and as a result, a growing trend in the telemedicine market. The dramatic shift from volume to value-based care delivery, combined with the emphasis we have seen on chronic condition management and population health, is propelling telemedicine forward and increasing physician support and adoption. We discussed the basics, the benefits, and many of the obstacles facing telemedicine today, but we also highlighted the progress being made with state and federal legislation, as well as where telemedicine is headed next. So without further ado, we're going to go ahead and open it up for questions. I want to thank all of you for listening to this presentation, and please feel free to type any questions you have in the chat box, and I will definitely try my best to answer them for you.
Hi, thank you, Lindsay. Wow, that was so much information, and I imagine that you just are beat from explaining it all. But thank you so much. I appreciate it. And everyone feel free to type questions in the questions panel of the webinar control panel. As a reminder, we will be sending out an email tomorrow with links to the recording as well as links to the just download the slides in a PDF form. So keep your eyes out for that. And also later today, we will be sending out a webinar invite for the final meaningful use rule. So keep your eyes out for that in the inbox as well. Okay, Lindsay, first question. Can you use Skype for video?
That's actually a great question. I did come across this in my research while I was making this presentation because I was curious as well. So what I found basically is that Skype is not HIPAA compliant. The biggest issue here when we think of telemedicine is going to be privacy and security of personalized health information. So HIPAA states that telemedicine appointments must be conducted through a fully encrypted and secure video platform with a company that's HIPAA compliant. So if we think back, HIPAA compliance depends on if you're a covered entity or a business associate. And as of now, Skype has publicly declared it won't actually enter into a business associate agreement with any of its users. So this means you should not be using Skype for telemedicine, and it will definitely lead to compliance issues with HIPAA and possible breaches or legal actions. So to reiterate, no Skype, please.
Okay, thank you. Next question. Do you have any information on payers other than Medicare or Medicaid in Texas? We're finding it difficult to get information about the coverage for telehealth or telemedicine.
So unfortunately, I don't know the exact answer to this regarding Texas, since, like I said, it really is an issue right now that each state is regulating and defining telehealth so differently. So I definitely understand the problems finding the information. I can research this for you, but the best advice I have to give to you right now is basically what we're seeing is the entire nation. So we see all those 49 state medical boards are reimbursing telehealth services as long as that physician is licensed in the same state that the patient is receiving the care in. So as of right now, commercial insurances, I'm seeing a large adoption rate, but again, you would have to research by your state.
Okay, great. Thank you, Lindsay. That's actually all the questions that we have right now, but Lindsay and I are going to stay online because somebody might be typing a question right now. But thank you, everybody, for joining us. Thank you, Lindsay, for walking us through all that. And please don't hesitate to let us know if you have any questions. And again, keep your eyes out for upcoming webinars.
Yes, thank you, everyone, so much.
Looks like most people are signing off, but we'll hang on just another minute here in case people are still typing. Okay, well, it looks like that's probably